Okay, hi everyone. We're going to get started here this morning. This is Behavioral Health 201. This is our third. Just a reminder to participate. If you have any questions, feel free to chat in or raise your hand. If you want to show your video, feel free to click in the bottom left to the camera recording. I just want to do a short plug for Umbrella. This is our new sort of central location for all types of learning communities, any materials for learning from IT. We've built out a module for 201. This is where you'll find recordings, the slides. If you see down here, we've even created an area where you can upload your coursework. The syllabus is also on here if you have any questions about the coursework. If you haven't logged into Umbrella yet, if you could connect with your practice consultant, if you have any questions or if you need your login info, they can absolutely help you get started there. Okay, I'm going to turn it over to Jonas.
I just want to say a couple things right at the beginning, again, about our kind of growing collaboration with the ASAP program. Again, you all know that we have a SAMHSA-funded project to integrate ASAP-trained social workers into primary care, and I think we have a full cohort signed up for the second year of that project, and certainly be interested in hearing from folks who want to participate in that in the future. And we have some very interesting research projects and important revalidation of the S2BI with some modified language that includes vaping products, and opportunity for practice to participate in a very, I think, low impact study where your practice can actually get paid to host an RA in the waiting room and do a very simple study. So let us know if you want to find out more information about that. Just want to remind you too of the consult line. No question or problem is too small, please call. And as Jane was saying, the sessions are, the recordings of the sessions are going up on Umbrella, and just know that the vaping session that we had last time is up there because this is such a growing problem and everybody keeps asking about it. We're trying to make that recording available to everybody, so remind your colleagues that haven't seen it that it's there. And without further ado, I want to turn it over to Miriam Schizer, who's going to lead us through our content today.
Thank you. Good morning, everyone. Thank you for spending this early morning hour learning about this topic. This is one of my favorite topics. And we'll be talking today about opioid use in adolescents. Great. I have nothing to disclose. So as you can imagine, this is a vast topic. I'll tell you what we'll be focusing on today. We're going to give you an understanding of the neurobiology of opioids. Obviously, the epidemiology of opioid use is an important part of this topic. I'd like to highlight the appropriate use of medication for treatment of patients with opioid use disorder. Certainly also highlight the role of Narcan or Naloxone for reversal of opioid overdose. And then we're going to finish by thinking about the role of parents and medical providers in ideally preventing this from ever occurring. I like to start with this image. This was a cover of the New York Times Sunday magazine in 2017. I find it so visually arresting. This article was entitled "Inside a Killer Drug Epidemic, a Look at America's Opioid Crisis." And this is why this is such an important topic. So I think I've always said to this audience that a picture is worth 1,000 words. You're looking at the number of drug deaths from overdose over the last few years, starting in 1999. And obviously this has been increasing at an alarming rate. I just found this breakdown fairly recently. This is data from the CDC, and the New York Times published this in 2018. And I think it puts this number, 70,000 deaths a year, in perspective. So you can see on the upper right of the screen, about 70,000 people died in 2017 in this country from drug overdoses. And what they've done is they've compared that to the number of people who died per year from other big problems of sources of mortality. And so you can see in 1972, this was apparently the year for peak car crash deaths, about 50,000 deaths from car crashes. Moving down the list on the right, peak HIV deaths in 1995. and then peak gun deaths. So you can see when we're talking about the number of people dying from drug overdoses, this is greater than these other very significant causes of mortality. And you can see in the lower part of the screen that we're seeing a large percentage of these overdose deaths from one particular drug, which is fentanyl. I was recently at a review course for the addiction medicine boards, and I saw this slide probably about 10 times. So this is a very important slide. And I want you to think about the opioid overdose deaths as really occurring in 3 different waves. And you can see this on the slide. The first wave of deaths was from prescription opioids, and we'll be talking about that momentarily. You can see that on the screen for natural and semi-synthetic opiates. Moving to the heroin wave, which was the second part of this wave. And then most recently, the very sharp curve on the right with a very steep slope is deaths from synthetic opioids other than methadone, which is fentanyl. That really is what that is. And I also want you to note that we're seeing an increase in deaths from stimulants. And you can see cocaine and methamphetamine also increasing at an alarming rate in the lower right part of the slide. Some of that is attributable to fentanyl. We know that we're seeing cocaine that is increasingly laced with fentanyl, but there also is this suggestion that we're going to be dealing with a big problem with stimulants as the opioid situation starts to improve. So today we're thinking about adolescents and young adults, and so this is data looking specifically at drug overdose death rates for adolescents. You can see between the ages of 15 and 19, and the time frame is very consistent for the story that I'm telling you today. So you can see that we start seeing this increase in around the turn of this last century, around 1999, in drug overdose deaths involving opioids, and you can see that continued to rise. And there is a suggestion that things have gotten better over the last few years. But again, look at opioids compared to the other substances, much lower on the graph. All right, I'd like to review terminology again so that we're all speaking the same language. A lot of people will use the term opiates and opioids interchangeably. Technically, that's not correct. When we're talking about opiates, these are naturally occurring compounds. If I had an audience in person, I would ask everyone what that is. The picture on the left, that's the opium poppy. And we know that there is a milky sap that can be distilled from the opium poppy, and then that contains morphine and codeine. So technically, when you're using the term opiates, these are natural compounds derived from the opium poppy. I like the term opioids because that essentially includes everything else. So you can see there are a number of different opioids that we need to think about. Most people are familiar with endorphins, which are endogenous opioids. I've already told you about opiates. And moving down the list, semi-synthetic opioids are derived from morphine and codeine, and there are some very important compounds in this class, including buprenorphine or Suboxone, which we'll talk about in a few minutes, heroin, and oxycodone. And I will point out that if you see an opiate screen on a drug test, that's going to test for morphine and codeine, which are the metabolites of heroin. So an opiate screen will test for heroin. And then I've already mentioned this category of fully synthetic opioids, which primarily are methadone and fentanyl. So again, if in doubt, use the term opioid because that refers to all of these compounds. I'd like to review opioid receptors and physiology. Suffice it to say that there are 3 different opioid receptors in the central nervous system, but for the purposes of opioid use, we really only need to think of one of these receptors, which is the mu-opioid receptor. So suffice it to know that there are other receptors and other endogenous ligands that play a role. Let's think about areas that are rich in these mu-opioid receptors. And generally, we're going to think about parts of the body that are associated with pain perception. Obviously, opioids have become an important source of pain control, reward pathways, respiratory function. This is all in the brain, the spinal cord, the GI tract, and peripheral regions. I think it's important to think about the mu-opioid receptors in the spinal cord. So in the setting of tissue damage, let's say someone is in a motor vehicle accident, you have these opioid receptors that become available. And so if you were to give someone a large dose of fentanyl after they were in a car accident, then they're not going to feel euphoria, they're not going to overdose because you have these receptors that are available. If someone is using opioids not in that setting, then there's binding that becomes more significant, such as in the prefrontal cortex. Typically, patients who are taking opioids for acute pain don't experience euphoria. that we see that more with recreational use. The limbic system plays a very large role in any substance with addictive potential. That's where you get the reward pathway. And then the brainstem is also very important. We know that opioid overdose deaths are typically from cardiovascular collapse and respiratory depression due to binding in the brainstem. All right, somebody shared this cartoon with me. This is very important. When someone is using an opioid regularly, there's a phenomenon called upregulation of receptors, which means that you get proliferation of these receptors, and this is part of the phenomenon of tolerance and withdrawal. Okay, I didn't see all the graphics until today. Very cool. All right. So if you have binding of opioids to these mu opioid receptors in the central nervous system, let's again review these important effects. We know that there's an analgesic effect, sedation, in some instances euphoria. I think most folks are familiar with constricted pupils as a side effect of opioid use. Again, decreased heart rate, decreased respiration, and this is often what occurs in the overdose setting. And then opioids can cause nausea, typically. Constipation is really the #1 annoying side effect of opioids, and this has to do with opioid receptors in the gut, which will lead to a decrease in motility. All right, so one of the things that you should definitely master after this webinar would be, what does a patient look like with opioid intoxication? That's a really important point. And what I like to say is this is a classic downer, if you're familiar with that terminology. So patients who are using an opioid are calm, they can have euphoria, particularly in the beginning, they're somnolent. A typical boards question would be somebody who has nodding off, who's perhaps an adolescent at dinner or in a classroom who has this head nodding. If you're thinking of a drug of abuse, you want to think of opioids. Other signs would include decreased heart rate, decreased respiratory rate. Again, breathing is affected. You can see shallow breathing. I've already mentioned the pinpoint pupils. And again, these patients are sedated. They might have slurred speech. Everything is a little slower when you've used an opioid. Tolerance and withdrawal are two very important phenomena associated with opioid use. Tolerance, I'm not sure we've talked about that in one of these sessions before. This is defined as the need for increasing amounts of a substance over time to achieve the desired effect. And some substances of abuse are associated with tolerance, others are not, but clearly opioids have this property. And think about my little cartoon with the upregulation of receptors, and that's really what's behind this. Withdrawal is also very important, also related to this proliferation of receptors. And this is a normal physiological response due to a rapid decline in receptor binding. So this could be due to decreased availability of the opioid or the presence of a blocking agent, such as Naltrexone, which we'll talk about, or Narcan. And a point that I like to make is if someone is taking opioids as prescribed, let's say this is a patient with chronic pain who's on an opioid regimen, there's no question that they'll develop tolerance and withdrawal if there's an interruption in their medication. And so if you're thinking about an opioid use disorder, those two criteria alone wouldn't make you think of an opioid use disorder because it really is just physiologic. So again, tolerance to opioid effects is an important property. Generally, this involves a change in receptor number and functioning. What's interesting is that depending on the property of the opioids, there's differential tolerance that develops. For example, patients will continue to have pinpoint pupils. We don't see that change. And constipation also doesn't improve for the duration of when someone is using an opioid. On the other hand, I would say euphoria is the property that gets lost the soonest. Patients who are using opioids daily are no longer experiencing euphoria. There's also tolerance to the sedation effects and the respiratory depression. A very important point is that if an individual has a period of abstinence from opioid use, they stop using, perhaps they're in treatment or some other reason, they're incarcerated, is they will over time lose this tolerance, and this makes them at risk for overdose, because if they go back to using, particularly if they use a similar dose that they were using, then they are set up for an overdose. So tolerance is a dynamic state. I'd also like you to have a very good understanding of opioid withdrawal, because this is a really important part of the story. I know my patients refer to this as feeling dope sick. So there is a very well-defined set of signs and symptoms that occur typically when someone is using an opioid regularly and then there's some sort of interruption. And I think if you wanted to have a shorthand for remembering what this is, it's like a really bad case of the flu. When we're screening parents to see if they've seen any evidence of opioid use, you want to ask, does your child look like they're having the flu in a recurrent fashion? Typically, these patients feel really ill. What's interesting is that opioid withdrawal is not life-threatening. The two substances that are associated with life-threatening withdrawal are alcohol and benzodiazepine. So even though this isn't life-threatening, because the patients feel so sick, they will do anything to avoid it. There can be temperature symptoms. You can have fever, flushing, chills, that sort of thing. The myalgias are really profound. These patients are in a lot of pain. Imagine the last time you had the flu squared. It would be that sort of achiness. GI symptoms are paramount. Patients have abdominal cramping, nausea, vomiting, and diarrhea. And then there is definitely a psychological component that goes along with it, which is typically anxiety, and patients can have profound dysphoria, and patients can actually be suicidal. Whenever I say it's not life-threatening, I would say except for that aspect of this. In terms of signs, we will often score patients for withdrawal, so I'm very familiar with these signs. You see a lot of autonomic signs such as increased heart rate, increased blood pressure, dilated pupils, which is what you'd expect. There's a very interesting pathological yawning that's observed. It's different than regular yawning. You can see it with these patients. And then they have goosebumps. I'm not sure what the technical term is for that. And they also look like they have a bad cold. They have nasal congestion and runny eyes. So this is what opioid withdrawal looks like. So the timing of these symptoms depends on whether you've used a short-acting or a long-acting opioid. With short-acting opioids, the best examples would be heroin or oxycodone. Generally, these symptoms will start fairly quickly, typically as soon as 6 hours after someone has last used. It tends to be fast and furious. The symptoms will peak after about 36 to 72 hours. And then after about 5 days, patients start to feel better. For long-acting opioids, methadone has a very long half-life, so everything is shifted later. Withdrawal symptoms will typically start about 36 to 48 hours after the last dose. Symptoms will peak probably 6 days, and then the duration will be longer as well. And I think it's important to think about, an example would be a daily heroin user. As I mentioned, the euphoria disappears very quickly, and so patients get caught in this cycle where they're not using to get that euphoric feeling, they're really using just to not feel sick. That starts very early on. I like to just spend a minute talking about the history of the opioid epidemic, and hopefully you've gotten an article by Sharon Levy, which gives a nice historical overview. Certainly opioids have been around since, I think, 3000 BC. These have been around for thousands of years. Moving more towards the present, morphine, I think, was patented in the beginning of the 19th century. The Civil War was an important turning point for two reasons. One is morphine was more widely available, and also this coincided with the development or the invention of the hypodermic syringe. So that led to a wave of an opioid epidemic, as it were. Then what was interesting is in 1914, the Harrison Drug Act was passed, which specifically prohibited physicians from prescribing opioid agonists, particularly for patients who had developed what we now call opioid use disorder. So fast forward to the Vietnam War, and a number of soldiers became addicted to heroin over in Vietnam, and then they came back. And what was interesting is they were a more sympathetic population because they were veterans, and so there was new attention paid to this problem of opioid use disorder. Then in 1974, this was the introduction of the methadone clinic for agonist therapy. And what was interesting, and this has to do with some of the legality of it, is methadone clinics were established as outside of mainstream medicine. In other words, you weren't going to go to a hospital, you were going to a freestanding methadone clinic. And we're still struggling with that today. The marginalization of substance use is a really good example. All right, so fast forward to the end of this last century, the beginning of this century, and there was suddenly an enormous amount of attention paid to treatment of pain. Physicians were implored to do a better job to treat their patients with chronic pain. Pain was introduced as a vital sign. And around this same time is correlated with the introduction of very potent opioid analgesics. And it's very chilling when you look at some of the early reports saying, physicians should use these medications, they're non-addictive. It's very chilling when you review the history. I like to show this just for fun. Apparently, heroin was first introduced by Bayer Pharmaceuticals in the late 19th century for treatment of cough and cold. And so parents were actually giving their children heroin for minor illnesses. So I think that didn't last very long, but it's interesting history. This is another very important slide. I think it really captures what led to the opioid crisis that we're still struggling with. So this slide shows you the number of prescriptions for opioids comparing, let's say, the early 1990s to about 2010. And what happened is, given this new attention to pain, there was an exponential increase in the number of prescriptions that were written, essentially a tripling of prescriptions. And this was more of a problem in the United States. I remember something like 95% of the world's supply of Vicodin was prescribed in this country. So really kind of astounding, staggering numbers. So unfortunately, what this led to is it led to the creation of an opioid reservoir, because typically what would happen would be a patient would get a prescription for an opioid, maybe use a small fraction of it, and then leave it in a medicine cabinet. And this became very accessible on many levels. And certainly we know for our adolescent population that this was a big part of the problem, that something like 85% of adolescents using opioids were able to get them easily from a family member or a peer who had gotten them from a family member. So think about this enormous opioid reservoir that was created. So again, bringing this conversation back to adolescents, this is data from the Monitoring the Future survey, which we've talked about many times, looking at opioid misuse rates. Again, we're focusing on 12th graders today, and the pictures all tell the same story. You can see, looking at the curve starting in the early 1990s, and you can see the steady increase in rates of opioid misuse. And it does look like, on a positive note, that those rates are now decreasing. And this has to do with better prescribing and a lot more education that has taken place. So the answers to these questions are strikingly similar, no matter what study you read. So what drove this phenomenon of opioid misuse was really primarily the accessibility and the availability. If you think about the picture of the woman sitting with all of those prescriptions. So adolescents were asked about opioid misuse. Why are you using it? It's easy to get. It's not technically illegal. It's easy to get someone else's prescription. And I think something that's a really important takeaway is that patients often think that if they're misusing a prescription drug, that it's intrinsically safer than using a street drug. And the idea is that a physician somewhere wrote a prescription for this medication, so it must be by definition safe. And if you remember the slides in the beginning of this talk, obviously there's a lethality associated with prescription drugs as much as there is with street drugs. But this is really a lot of what drove this phenomenon. And then another part of the story, remember I mentioned in the beginning, there was the prescription opioid wave followed by the heroin wave. Typically what happens is for patients who are misusing prescription opioids, at some point cost becomes a factor. Prescription opioids are more expensive if you're buying them on the street. And so patients would often switch to heroin use. And I remember a patient taught me years ago that generally you're paying $1 a milligram. So imagine someone who's using Percocet, patients call them Perc 30s, which is 30 milligrams of oxycodone in Percocet. I remember a patient who would use 6 Perc 30s a day. So I want everyone to do the math with me. That's about $180. And very few people have that kind of money to spend, which is why you often see stealing in patients with opioid use disorders. But anyway, at some point, they will switch over to heroin. And another part of this trend that's important is in the same time frame, there was a striking increase in the purity of heroin that was available on the street. And so when you think about heroin use in the 60s or 70s, patients would typically inject it. But in this era, in the current era, you can also get the same high by snorting it or via insufflation. And often there's less of a barrier. Patients will say, well, I'm never going to become someone who, shoots up, who uses injection drug use, but patients will feel less of a problem snorting heroin. Certainly, over the same time frame, again, the first wave was the prescription opioids, and then we have seen a steady increase in heroin use, and this is data showing anyone age 12 and older. So that's definitely part of this story. All right, now we're going to focus on adolescents and what we call non-medical use of prescription drugs. Certainly something you've heard me say before, and we know this across the board, is that the younger an adolescent is when they start using a substance, the more likely they are to develop a fulminant problem. And so not surprisingly, we see this phenomenon with non-medical use of prescription drugs. You can see the younger adolescents are more likely to develop a use disorder compared to the older adolescents. All right, so let's think about risk factors for opioid misuse. We know that one of the risk factors is getting a prescription for an opioid. And so let's tease this out a little bit more. So we know that if a patient gets a prescription for an opioid, obviously this young woman had some sort of musculoskeletal injury, you have an increased risk of subsequent misuse. And I think this is two reasons, excuse me. Number one is availability. So if you had a prescription, let's say you used a few, it's sitting in your medicine cabinet, and then you might use it again at a later time. And also there is a subset of patients that, for reasons I don't think we fully understand, who are more likely to develop some sort of a euphoric reaction when they take an opioid. And so giving someone a prescription and then having that reaction puts that person more at risk for subsequent misuse. We also have to be mindful of whether this patient who has a prescription for an opioid has ever used any other substance. So we know that someone with, these are adolescents specifically, someone who's used tobacco, alcohol, or marijuana in the past, if you look at the odds ratios, will have an increased likelihood of going on to misuse opioids. And what's interesting is the highest odds ratio in this paper is reported for females with a history of marijuana use. So what happens is, we know that getting a prescription for an opioid is a risk factor. Certainly this risk is magnified if someone has a history of previous substance use, and then this creates a potential situation for opioid misuse. And then there are a host of other factors which will intervene, as it were, to determine whether this individual will go on to develop an opioid use disorder. And some of these factors, we just talked about age as a factor. We know that there's a huge genetic component for substance use. Generally, the number that's quoted is there's about 50% of substance use disorders have a genetic component, so very high genetic component. And then we're going to talk in a moment about mental health disorders, and then what is the motivation for misuse. That's going to play a role as well. So it's really important to think about whether this patient who's misusing opioids has any mental health diagnoses, because this is going to give you a much greater likelihood of going on to develop opioid misuse and potentially an opioid use disorder, so that we know with patients who have a history of depression, anxiety, or panic disorder are more at risk for opioid misuse and opioid use disorder. Certainly if you have a family history of substance use, you can see the odds ratio goes quite higher. And then we know that patients with trauma are exquisitely at risk in general for developing hard to treat substance use disorders. So you can see the patient on the right with PTSD has a very high odds ratio. All right, the last thing in this category that I would talk about is you also want to think about what was the adolescent's motivation for misusing an opioid. So they're using an opioid, and then you want to kind of stratify into risk categories in terms of developing an opioid use disorder. So generally, there are two populations that have been described. Adolescents might misuse an opioid, and whenever I use that phrase, I mean taking an opioid that wasn't prescribed. So if they're self-treating some sort of a pain symptom, that would be one category, versus the patients who are using it recreationally. So they want to get high, so they're going and trying their opioid. And I think, a lot of this is what you would expect. It turns out that if the motivation for misusing an opioid is self-medication for pain, these patients are less likely to go on to develop an opioid use disorder, versus the patients whose motivation is recreational use are significantly more at risk. All right, so let's turn the spotlight now on opioid addiction for patients with severe opioid use disorder. We reviewed this criteria briefly when we talked about SBIRT in the first session. And so these are the 11 criteria that are presented to us in the DSM-5. And we use these criteria to diagnose any substance use disorder. So I'd like to spend a minute reviewing them. So again, these are yes or no questions. And the more yeses you endorse, the more severe your substance use disorder. So we are asking patients, have they used more or for a longer period of time than they intended? Are they trying to cut down or quit, but it's harder than they thought? excessive time spent taking the drug, failure to fulfill major obligations. That really is important because that captures a deterioration in function. Continued use despite knowledge of problems. They're giving up activities that used to be important to them. This is an important one as well. Recurrent use in physically hazardous situations. Continued use despite interpersonal problems. Again, I did mention tolerance and withdrawal, that you will see both of those criteria for patients who are taking opioids as prescribed. So those two will not alone give you an opioid use disorder in that context. And then this very important craving question that was added in 2013. So just a nice reminder that if you give 2 to 3 of these criteria, with the exception that would be mild opioid disorder, 4 to 5 would be moderate, and then this broad category of 6 or more out of 11 would be severe. And I will mention that when we see a patient presenting with a severe opioid use disorder, typically they're giving us 11 out of 11. This tends to be really a fulminant presentation. So let's focus on treatment of patients with opioid use disorder. I'm presenting you with 2 important categories. You have your non-pharmacologic treatment and then your pharmacologic treatment. In terms of non-pharmacologic treatment, these patients typically need more treatment, more intensive treatment up front compared to, let's say, patients with cannabis use disorders. It's not uncommon for a patient to need a higher level of care right at the beginning of treatment for stabilization. And if it's not going to be residential treatment, then remember the alphabet soup of intensive outpatient programs, IOPs, or partial hospital programs. Definitely patients do well with 12-step meetings. This is more for maintenance treatment. Individual therapy is always going to be a mainstay. We know that family therapy is very validated and well proven in adolescent substance use disorder settings. And then some of these patients are going to require some sort of a special school setting, such as a therapeutic school, or I'm grateful that we have some excellent recovery high schools in Massachusetts. Now we're going to talk about the pharmacologic management of these patients. And I want you to think about the management of opioid withdrawal symptoms as the first arm, and then more long-term therapy, which will be either via an agonist or an antagonist. We're going to say more about that. So again, it's really important that you understand that opioid withdrawal is a really important part of what perpetuates this cycle of ongoing opioid use. Patients are using not to experience euphoria, but really to not feel sick. And so giving them medical support for these withdrawal symptoms can be a very important initiation so that they can then begin treatment. We know clonidine works super well for a lot of the autonomic symptoms, and this makes patients feel better. You can treat the GI symptoms directly with something like loperamide. Now we have Zofran, which works well for nausea and vomiting. And again, the achiness is really profound, and so we try to treat that with ibuprofen and acetaminophen. I should say that ideally you would convince patients to go into a facility for treatment of opioid withdrawal, and then in that setting they're often given some sort of a brief agonist therapy with a taper. So this can be done with methadone or buprenorphine. Now, it's funny, before I started doing this for a living, I remember the phrase of someone who's been in and out of detox and isn't getting better. And the point that I'd like to make today is that what we used to call detox is not definitive therapy. And so it makes sense to me now that merely treating someone for the symptoms of opioid withdrawal wouldn't necessarily mean that you've treated them. And so this is the beginning of treatment, but it's not definitive. All right, so I would like to say a few words about medication for opioid use disorder. We have buprenorphine, and if I say Suboxone, I apologize. I'm not endorsing a product, but that's often how people refer to buprenorphine. It's the most common brand name. I'd encourage all of you to read the policy statement that was published by the American Academy of Pediatrics in 2016, discussing medication-assisted treatment for adolescents with opioid use disorder. We know that this is a chronic medical condition. We know that medication works. And so this policy statement is beautifully written, and it really is a call to action for pediatricians to take on this problem. This is a little bit of an aside, but I think it's really important. We're moving away from the term medication-assisted treatment. I wanted to give a little bit of a shout out to trying to move away from stigmatizing language. This has become a very important theme in the field of addiction medicine, and I like this summary from Boston Medical Center. There are a lot of words that we don't even notice, we take for granted, but if you stop and think about it, there's definitely a stigma associated with this, and we're trying to move away from it. So medication-assisted treatment,
1.2 did, yeah.
insulin, or diabetes medication-assisted treatment. It kind of takes away from the significance of the medication. So it's unfortunate that the policy statement uses that term. We are trying to move away from it. You can see the word addict appears. So definitely at your convenience, come back to this list and try to move away from stigmatizing language. Okay, thanks. All right, so I'd like to focus on the two different types of medication that we use for treatment of patients with opioid use disorder. And it's important, again, to go back to the mu opioid receptor and think about how these compounds work so that you'll have a good understanding of it. And we're going to talk about three categories: full agonists, partial agonists, and antagonists at the mu opioid receptor. So if you're thinking of a full opioid agonist, my little cartoon shows a perfect kind of a lock and key fit at the receptor. And these agonists would be methadone or heroin oxycodone. So generally, these have the strongest impact at the opioid receptor. And as such, they are the most reinforcing, and they also have the greatest potential for abuse. So buprenorphine is a unique category. It's a partial opioid agonist, and that's a property that's exploited in the treatment. And so because it's a partial agonist, it's not a perfect fit. That means that it doesn't have the full agonist effect. Patients feel better because it gently stimulates the receptor, but they don't feel high. They have a sense of well-being from being on buprenorphine, but they don't actually experience a high, which means that there's less potential for abuse. The property that ties in is that it also has some antagonist properties, which means that if you have buprenorphine sitting on this receptor because you're prescribed it, if you were to use heroin or oxycodone, buprenorphine has a greater affinity, and so that full opioid is not going to have an effect. And so patients know that if they're taking buprenorphine, it doesn't really pay to use something else, to use something, because it won't have an effect. And that's really part of the chronic management of buprenorphine. All right, so the last category would be...
so there's somebody who's not on mute, so if you could tell, that'd be great. All right, go for it.
Great, thanks, Brad. All right, so naltrexone, and I also want you to think about naloxone in this category. These are opioid antagonists. And what that means is they will sit on the receptor. They don't have any effect on the receptor. There are no opioid effects associated with using an antagonist. But because they tend to have a very strong affinity for the receptor, they're not going to allow anything else to bind. So certainly for naloxone as an opioid reversal agent, it's going to kick off the agonist that's sitting on the receptor, and that's why someone is resuscitated. If you're using naltrexone as a medication, it also means that if someone were to use heroin or oxycodone, there would be no effect. And so what we see over time is there's a gradual extinction of cravings for opioids because patients realize that, you know, it wouldn't do anything for them, as it were. I'm not going to say a lot about methadone. We don't see a lot of methadone in our adolescent population. Generally, as I said before, this has to be prescribed in the setting of methadone clinics. Over the years, we have had a handful of patients who didn't do well in our buprenorphine program, and so they ended up graduating to a methadone clinic. And I will say that for patients who really need the structure of going to a methadone clinic every day, for some patients it can be highly beneficial. And I think as healthcare providers, it's important for you to have an understanding of methadone, how it works, and just knowing that it's out there. So we talked about buprenorphine. You know, the brilliance is that it's a partial agonist, so it's less reinforcing and can be used for chronic maintenance. So this was FDA approved in 2002 for use in general office settings. And again, it really was life-changing because patients could be treated in a primary care setting or in an office setting without needing to go to a clinic. Now it's interesting, buprenorphine is it's almost always conjugated with naloxone, and there's a very important reason for this. So buprenorphine is taken sublingually. You won't absorb it. The bioavailability doesn't work if you take it orally. And it turns out that naloxone, if you take it sublingually, naloxone just goes on for the ride. It's not going to have an effect. But this is meant to deter patients from trying to misuse their buprenorphine. If someone were to crush it and inject it to see if they could get high from their buprenorphine, in that case, the naloxone would kick in and it would cause a severe precipitated withdrawal. So again, typically buprenorphine is prescribed as this conjugated product to deter misuse of the medication. We know that it comes in tablets. Early on, there was a problem with accidental ingestion. Small children, some of these had fatal outcomes. And so it was also branded as a film. Patients, again, will put this under their tongue, take it sublingually, and the packaging is fantastic. I've opened these films myself, and you need a little scissors, and it takes a lot of fine motor skills. So this really did address the problem of accidental ingestion. Generally, buprenorphine is well tolerated. I mentioned constipation is the most significant side effect for opioids, so that's true for buprenorphine as well. There are very few significant drug interactions, and so patients generally tolerate it very well. I did want to mention this phenomenon of diversion. Generally, with buprenorphine, you want to, if you're prescribing buprenorphine, you want to keep very careful track of how much you're prescribing. Patients need to bring it to you so that you can do pill counts or film counts. And the idea is that if someone wanted to sell their buprenorphine, there is a street value. And typically the people who are buying buprenorphine or Suboxone are people who have these opioid use disorder. Perhaps they can't get an opioid for a day or so. They're feeling dope sick, which is how patients refer to this. And so they'll buy a Suboxone just to get them through that day. Very few people will buy buprenorphine to, for an opioid high because it doesn't really give you one. All right, so Woody is often quoted in terms of the beginning of a research base as to how buprenorphine works. There was a study that was published in 2008 looking at a comparison between patients who were given buprenorphine in the setting of 2 weeks of medical detoxification versus more chronic treatment, which at that point was 12 weeks of buprenorphine. All of these patients had follow-up and counseling, but again, one group had medication for only 2 weeks and the other group had medication for 12 weeks. And what was really striking is the patients who were continuing to receive buprenorphine had better retention in treatment and fewer opioid positive drug tests. These are the two things that we tend to follow in studies such as this. And so the argument was made, if patients do well in 12 weeks, why stop at 12 weeks? And we will typically treat patients with buprenorphine for a minimum of a year, and some patients will remain on it for quite a bit longer. All right, so hopefully some of you are listening to this thinking about, hey, I would be interested in prescribing buprenorphine. In order to do this, you would need to do an 8-hour training course so that you can get a special waiver from the DEA allowing you to prescribe buprenorphine. Typically, this is done either as an 8-hour in-person course, or there's also a half-and-half version, which is 4 hours of online training, 4 hours of in-person. We are doing these all the time. I know I have one coming up for the adolescent medicine folks at Boston Children's. And so please, if you have interest, let us know, and we would love to include you in a training session. So we know that our population of adolescents and young adults are underserved. This is a picture showing you that 750,000 physicians can prescribe addictive pain medications. 37,000 have been trained to prescribe addiction treatment in general. Only half actually do. And then this is the really dramatic part. 1% of patients are pediatricians. And so if you look at who's gotten waivered in this country, there's really only a fraction who are pediatricians. So we really do have a very underserved population for our young people. And we know the treatment works. This is for those of you who know Shannon Mountain Ray, who is at ASAP, one of our fantastic social workers. And this was, I think, on the cover of the Boston Globe. And this is the work that Jonas was highlighting for a trained social worker to go into a practice, and so that they become much more comfortable treating patients with opioid use disorder. And again, I told you about stigmatizing language, so it looks like the Boston Globe was unaware. Pediatricians are treating opioid addicts. We don't like that term, but it was still a fantastic article. So this works. We know this works.
And this idea of training physicians to prescribe buprenorphine is an explicit goal of this ASAP-PC project. And whether you're working in a practice that integrates a clinician or not, we want to train as many providers in the network to do this. It is a very low incidence sort of thing, But as we actually had a story related to that on the Today Show, and it featured the patient that was treated here at Wareham, and in the low incidence, low occurrence sort of thing, absolutely life-saving. I mean, he talks about it in the Today Show piece that we can share with folks. So I want to encourage you to be prepared, to get trained and be prepared. If this occurs, it can be absolutely life-saving.
Thank you, Jonas. I think last year we actually showed a clip from the Today Show.
Yeah.
So I would encourage you, if you have a chance to watch it, it's really profoundly moving what they were able to accomplish. All right, so I'll say a few words about naltrexone. We've mentioned that this is an opioid antagonist. And so if someone is taking naltrexone, it will block any euphoric effects of opioid use. And we have a lot of studies that show that this medication works. Typically what's done is, for naltrexone, is that you start with an oral dose, typically about 50 milligrams a day. And then once you've demonstrated that the patient tolerates it and isn't having any side effects, then you transition to a long-acting preparation. Some of you may have heard of this as Vivitrol. We know the brand name. And then this is given as a once-a-month intragluteal injection. And we know that patients do better because you've taken compliance out of the issue. The one tricky part about starting naltrexone for treatment of opioid use disorder is that you need to wait about 7 days from when they last use an opioid to when you can start naltrexone. And the reason is, if you start it too soon and there's still an opioid on board, naltrexone does have a greater affinity, so you're going to displace the opioid, and patients will experience this as severe withdrawal. So if that happens, they're never going to come back and see you, and you've lost an opportunity. So ideally, if a patient would agree to go in for medical management of opioid withdrawal, they get medical treatment, and then 7 days after their last dose, they can start naltrexone. All right, I'm giving you this information on the slides. I'm going to kind of rush through them, but please feel free to go back and look at them more in depth. We do worry a little about hepatotoxicity with naltrexone, which really means that you get a baseline set of liver function tests at the start of treatment. Generally, patients do very well. All right, and this is what I was mentioning. We know that patients do better with the injection versus the oral, and largely this is because of compliance. People just don't take their medication every day. All right, so if you are treating patients with either buprenorphine or naltrexone, this is something that you have to approach very protocolized way. And so typically we have a contract that patients sign if they're starting buprenorphine, and we spend a lot of time upfront reviewing what we expect. And this includes regular visits. We see these patients weekly in the beginning. Pill counts, as I mentioned, because of the potential for diversion. Patients absolutely must agree to regular urine drug screens, and you are doing two things. You're looking for the medication in the urine, so you know they're taking it, and you're also monitoring for any other use. Another important point is that we always insist that patients agree to not use alcohol and/or benzodiazepines while we're prescribing buprenorphine. And I don't think I mentioned that buprenorphine is generally very safe. It has a ceiling effect compared to full agonists, which means that as you increase the dose, the effects level off. So it's very unusual to develop an overdose with buprenorphine. The exception is if they're using other central nervous system depressants, such as alcohol or benzodiazepines, you can lose that ceiling effect. So patients have to agree, no alcohol, no benzos while they're taking buprenorphine. We have a naltrexone contract, and again, the idea is that this is something that you want to be, you're really going to micromanage these patients while they're on these medications. All right, so in terms of the monitoring, I mentioned regular visits. We do pill counts just because there is that potential for diversion. And also if someone wanted to use an opioid, they wouldn't take their medication. And so you might see that they have more medication remaining than they should instead of less medication. I like to say to my patients when we're starting Suboxone that it's not a magic pill, and that during their treatment for opioid use disorder, the counseling or psychosocial support is really going to be key. These patients must engage in regular counseling. As I mentioned, 12-step meetings can also be helpful, but you can never ignore that piece while you're giving someone medication. We will talk in January about patients with mental health disorders and substance use disorders. And so it's, as you would expect, it's very important to treat the mental health disorder at the same time as you're treating the opioid use disorder. I'd like to say a couple of words about naloxone. This is Narcan for the treatment of opioid overdose. So naloxone is an opioid antagonist. If you give it, then you will kind of kick the opioid off the receptor, and then patients can be resuscitated. It works very quickly, and there's really no contraindication. If somebody has collapsed in the field and you're not sure if they've used an opioid or not, there's really no downside in giving this to them. I think it's really important for this group to understand risk factors for opioid overdose. I would say really the top of the list is what are they using? What is the opioid dose and what is the purity? We're seeing more and more fentanyl use, which has been driving this increased rate of overdose deaths. And just to give you an example, if morphine is a 1, we know that heroin is twice as potent as morphine, and then fentanyl is 100 times more potent than morphine. And what's really scary now is we're having patients at ASAP where fentanyl is their drug of choice. They're not just using a substance laced with fentanyl, they're going for the fentanyl. We know that patients who have polydrug use are more at risk for overdoses, particularly if they're using other depressants such as alcohol or benzodiazepines. We worry about patients who are using alone because if they overdose, no one is there obviously to resuscitate them. Patients with chronic medical conditions are more at risk for overdose. And then it's really important to know their history. What's their history of substance use over time, and have they ever had an overdose before? I was at a conference last week for addiction medicine, and I will say that emergency rooms are really doing heroic jobs trying to capture patients who are presenting with an overdose and engage them in treatment immediately by starting buprenorphine, because we know that these patients have a profound risk of dying from an overdose even within 2 days of being released from the ER after an overdose. I mentioned before that patients who are abstinent from opioids are a unique population at risk from overdose, and that really has to do with the fact that they've lost their tolerance. Imagine someone who's incarcerated, they haven't used opioids, they're released, and then they might use the same dose that they had previously, only because they have lost their tolerance. This will be fatal. All right, so again, how to respond to an overdose. You should administer Narcan, call 911. These days we're prescribing it as intranasal naloxone, where you would squirt 2 mLs into each nostril. There's also an auto injector, think of an EpiPen, but if you can avoid sharps, that's always preferred. All right, so we're going to talk about advice for parents. I've always enjoyed being a pediatrician with this phenomenon of anticipatory guidance. So there's a lot that you can do with opioid use disorder. Generally, as I mentioned, alcohol and marijuana use really is a risk factor for opioid misuse and then further progression. So this can be part of your conversation with parents as to why there are significant risks associated with using alcohol and marijuana. This sort of looked familiar. We talked about how a lot of what drove this was accessibility. And so I think at every visit, if you can figure out a way to ask parents if there's anything in the house, any medications with potential for abuse, best thing to do would be to get rid of those medications. If someone is taking them, then make sure they're in a lockbox. All right, so anticipatory guidance. Also, parents should set a good example. They should talk about this frequently, and nobody in the family should be sharing medications. I think a lot of people will do that, but it just sends the wrong message to adolescents that you don't want to send them the message that it's okay to use someone else's prescriptions. All right, so finishing with medical professionals. Again, during the same time period that we're highlighting from the 1990s to 2010, pediatricians and other treaters of adolescents and young adults were all guilty of increased prescriptions for controlled substances. And so we were not exempt from this, but I think everyone is more aware now of the profound risks associated with this. So in general, if you're treating someone with some sort of an acute pain syndrome, the most important thing to do is to maximize all the therapy that does not involve opioids. And that could be physical therapy, ice, other medications. The picture on the right, lower right, reminds me to mention patients with depression and anxiety tend to be a little harder to treat from a pain standpoint, but it's a double-edged sword because they're also more likely to misuse prescription medications. So you want to really do a good job thinking about patients with pain, depression, anxiety with that constellation. If you are thinking about prescribing an opioid, it's really important to screen. We had that talk about SBIRT, so you know how to screen. If someone has a history of substance use, you want to proceed with extreme caution. And certainly if you uncover opioid use, then you want to think about treating them for that. So caution when prescribing opioids. If you are going to prescribe an opioid, then the parent should be in charge. You want to be very careful with it, and it should be discarded as soon as the prescription the time period has ended. I'll end with this. This is the voluntary non-opioid directive. This was part of Governor Baker's opioid legislation. I think it was in 2016. It's a wonderful conversation to have with your families. Patients can volunteer to sign this. This is a voluntary directive. If they sign this form, they're saying, I don't want to be prescribed an opioid. We have a way of putting this in the electronic medical record at Boston Children's Hospital. I think the most important part of this is not so much whether they sign it or not, but having the conversation, because it alerts people to the dangers of getting even one prescription for an opioid. So just like we talked about the contract for life, I would become familiar with this form and integrate it into your well visits. So in conclusion, opioid use among adolescents and young adults is a serious problem with obvious, potentially life-threatening consequences. And there's a lot that this audience can do to have a positive impact. So in no particular order, screening our patients for opioid use, using great caution in prescribing opioids, having this part of your conversation on a regular basis, talking to patients and parents about this phenomenon of misusing prescription drugs. And then on one end of the spectrum, for patients with severe opioid use disorders, we have medications and they work and they can save lives. And then if there's something in a family that tells you that they're high risk, then they should not leave your office without a prescription for Narcan or Naloxone. All right, lots of people involved, and I'll take questions. Thanks so much.
We have a couple. First question, when would you use Naltrexone instead of Suboxone?
Thank you. That's a fantastic question. I think, generally, if you look at the ASAP experience, we are more likely to use buprenorphine or Suboxone. I think it's more reinforcing in general. Patients tend to do better on it. Usually, if you're going to Naltrexone, there's some sort of a reason why a patient wouldn't want to be on buprenorphine. For Naltrexone, these patients can be monitored a little less closely. They should still have regular urine drug screens, but they wouldn't necessarily need to come in for weekly visits, weekly prescriptions. Patients can do very well on Naltrexone. I feel like in our experience, we are going to try buprenorphine first in most cases. The only exception, by the way, is someone with a severe alcohol use disorder. I've told you that I don't want someone drinking when they're on Suboxone, and Naltrexone is also FDA approved for the treatment of alcohol use disorder. So then it's a win-win if someone has both problems.
And then the second question is just around kind of real-time support for providers who go through the 8-hour training and kind of need an on-the-spot refresher. So would that be the ASAP consult line, or would that be some other?
Yeah, no, thank you for asking that question. Hey, Julie, how are you?
Yeah.
Because that means that you really appreciate that this is taking on something. I totally agree. Definitely, we're available 100%. Also, the PCSS is the instrument that is kind of supports these trainings, and they have a vast amount of resources. So the idea is that everyone who does this training needs training after the training, but there are a lot of resources, including ASAP, to support you along the way.
And we are very committed to those of you that do go through the training and become prepared to do this prescribing, to support you in any way we can. And I'll tell you that Sharon Levy got in the car and drove down to Wareham and was with the team when they did the first prescription. And about 15 minutes into it, they're like, well, thanks for coming. This is much easier than we thought it was, but thanks for coming. And, I can't guarantee Sharon Levy will get in the car and come to every one of you, but we will be available and present with you as much as we can and help you along the way. This is a big priority for us to get people prepared to do this, and we want to support it in every way possible.
And the only thing I'll add is you're likely, if you undertake this, you're not going to have 50 patients in the beginning. This is going to be episodic, and there is lots of support. Thank you, Jonas.
Yeah, it's a very small number of kids that need this treatment, but when we can deliver it, it is, game changer.
All right, so I know it's 8:30, but we have 2 more questions we can get through, hopefully. So the question is, do you have Narcan on hand in ASAP clinic? Do you think PCP offices should have Narcan on hand the way we have EpiPens or defibrillator?
Fantastic question, Eleanor. Yes and yes. I mean, we're in the hospital setting, so we do have Naloxone available. Absolutely. I think, and part of what I think Massachusetts has done a good job about is increasing the availability of Narcan, and there's no question that saved lives. So yes, it should definitely be very accessible in a pediatric practice. Oh, that was a really good, I want to address that question.
Okay, and then this one here, at one point, we said that patients treated with opioids for pain do not have euphoria, but at another point, he said that a risk factor for developing addiction is euphoria when they're prescribed it for pain.
Yeah, no, thank you.
Yeah.
Thank you for catching that nuance. That's a really great question. Generally, there's factors that we don't understand, but some patients, when they take an opioid, tend to have this reaction of euphoria. And it's interesting. I've heard patients say that they suddenly feel like they're in this warm, safe place, like they're seeing a beautiful sunset. So some patients do respond differently than others. But absolutely, someone in severe pain, if you give them fentanyl after a car accident, they're not going to experience any euphoria. Someone taking a prescription opioid in a different setting, there are people that appear to be more at risk because they have that reaction. And then what I was mentioning about the tolerance is, picture someone who's using heroin or perk 30s every day. Euphoria is really no longer part of the picture. And in that chronic phase of the cycle, they're continuing to use to avoid feeling sick. So thank you. That's a great question.
All right, and then our last question is, what do you think about marijuana use for harm reduction in young people being treated for opiates? One of my patients is going to a methadone clinic, is using it, and they are okay with it.
Yeah, no, thank you. That's another great question. I think I'll answer a question with, we do regular drug testing in our patients who are prescribed buprenorphine, and a lot of them are continuing to use marijuana. We're doing harm reduction because we don't say, if you continue to use marijuana, I'll stop prescribing buprenorphine. But again, my goal for every patient that I treat is eventually to get them off cannabis as well. So I think in all of these settings, it's not going to be a deal breaker, but they can do better, and I am going to try to get them off it. That's harm reduction. That's exactly right.
Okay. All right, everybody. Thanks for your time. Jane will get the slides and recording and other relevant materials out to you shortly after this meeting. All right, thanks.
Thank you.